Good afternoon, everyone, and welcome to the JMitra Scientific Webinar. Thank you for making the time on a Friday afternoon. We have a full hour ahead, so let me set the stage briefly and then get out of the way. Well, scrub typhus is a strange disease to work on. It is entirely treatable, toxicillin, cheap, widely available, and yet the WHO still calls it one of the most underdiagnosed and underreported diseases in the world. 1 million plus people affected every year, and 1 billion at risk. The gap is not the drug, the gap is always the diagnosis. Well, in endemic districts, scrub typhus hides behind dengue, behind malaria, behind enteric fever, and the test we rely on most often turn positive only after the patient's most dangerous week has passed. That's the problem our speaker will address today. Well, it is my privilege to introduce Professor Ashok Rattan. Sir is an MD in microbiology and a fellow of the National Academy of Medical Sciences. He has taught at AIIMS New Delhi, JNMC Aligarh, and Sharjah Medical College. He has directed reference laboratories across 3 continents, including CAREC, the PAHO WHO reference laboratory in the Caribbean and in India at SRL, Pathkind, and Radcliffe. He holds 30 international patents, and he has received the APJ Abul Kalam Award for lifetime contribution to diagnostics. But the line from his own biography that I think matters most today is this one. His current interest is taking essential diagnosis to the last mile. Well, that is exactly what this session is about. Professor Rattan, sir, the floor is yours, sir.
Thank you very much. Scrub typhus is one of the oldest recognized yet most persistently underdiagnosed febrile illness in Asia. It was first
Your mic
characterized.
is not on, sir. You can share your screen.
My screen is not on.
No, sir.
My presentation is not on.
No, sir. Now it's on, sir. It's on now, sir.
Okay.
Please go ahead, sir.
Now?
It's on, sir. We can see it now.
All right. So, it was first characterized in Japan more than a century ago. It nearly disappeared from Indian medical consciousness in the decade following independence, only to re-emerge forcefully from early 2000 onwards as molecular and serological diagnostic became more widely available and clinicians began systematically testing patients with undifferentiated febrile illness. At this moment, it is felt that it is common, is costly, and curable, but it's very difficult to miss, and the cost is in missing the diagnosis because the treatment is cheap. Untreated cases have a mortality up to 40%, while if a person is treated with cheap doxycycline or erythromycin, then the mortality is 5%. The takeaway from this webinar will be that accurate laboratory diagnosis within the first 10 days of fever is the single most important variable in reducing morbidity and mortality from scrub typhus. An illness that still hides inside the broader label of undifferentiated fever should be identified and treated quickly. Scrub typhus is caused by a gram-negative intracellular bacteria which is known as TsutsugamishiigMIgGCard. This disease, as I said, was known since 313 AD. The name is scrub, meaning vegetation type in which the vector is found. Typhus is because the fever causes stupor or a person feeling mentally weak. That's a Greek term, and Shushuga means small and dangerous, while Mushi means insect or mite. So it becomes ScrubTyphus or Shushigamushi. WHO states that it has been characterized as one of the world's most underdiagnosed, underreported disease. 1 million cases would be definitely underreporting, while 1 billion people are at risk. Untreated, as I said, mortality could range from 1% to 40% with an incubation period of 6 to 21 days. Orencia Tsutsugumushi is transmitted only by the bite of infected sugars, that is the larval stage. There is never person to person transmission. An immunodominant surface antigen known as TSA56 has been identified, and more than 20 antigenically distinct serotypes and genotypes have been identified as a consequence. You see the relative size of the mite. Adult mite is 8, while sugar, the larval stage, is 6 legs, and that is the one that bites. We know the pathogenesis and how the pathogen enters and then causes disease. It can infect every endothelial cell, and it multiplies in the cytoplasm. There was a time when it was felt that since the mite is present in an area known as Tsutsugumushi Triangle, extending from Russia on the east beyond Japan, going on till Pakistan and then to Australia, that the disease would occur only where Tsutsugumushi was available, and ScrubTyphus will be found here. In the recent past, because of various changes, including habitation into area which was forest, because of temperature, environmental drivers, etc., it appears that Tsutsugumushi Triangle is not the limiting factor as far as ScrubTyphus is concerned, but it can be found in Africa as well as in America. So the reality is that it has emerged it has been found not only in Dubai, as known as O. chotu, or in Chile, known as O. chilenis. And more than 1 million cases are estimated annually. This is the life cycle of the mite, and it is the larval stage which is infectious. The ScrubTyphus has been found wherever it's been looked for. It's mostly present after once it rains and the shrubs are there. It's mostly present in the rural environment, and who rub through or pass through shrubs, and you would find that in Himachal Pradesh and Uttarakhand, Uttar Pradesh as well as Rajasthan is very common. Similarly, Vellore has reported cases from Andhra Pradesh, from Karnataka, from Tamil Nadu, and of course there has been a huge outbreak in Mizoram too. The climate has definite influence over the cases of ScrubTyphus, and any increase 1 centigrade increase in mean temperature would decrease the cases of the vector as well as but whenever it rains and the relative humidity is high, the number of sugars will increase, As a consequence, the cases will also increase. Rodents are the vectors, are the reservoir on which the vectors survive, and as you notice there, as the number of sugars increase, scrub typhus cases in human beings also increase. So the risk factors, one risk factor is that the clinical manifestation vary from completely asymptomatic to severe to 50% mortality. The pathogen infects vascular endothelium and mononuclear cells, all organs including lungs, liver, kidney and CNS can be affected. Misdiagnosis and underdiagnosis is common as symptoms are non-specific, especially in the absence of SCHAR, and then they are called acute undifferentiated fever, where the differential diagnosis, since it occurs during the monsoon, would be malaria, could be dengue, leptospira, and enteric fever, and of course maybe I should add acute encephalitis syndrome, which used to occur in Gorakhpur. There is no person-to-person transmission, and transmission is only by the bites of sugars, which survive on the shrubs as you see on the right side. And this is the size of the shrub of the sugars on the leaf of this. Once they bite in an exposed area, there is a painless black scrub with erythematous halo, and there's edema. It appears a few days before symptoms appear. It's common in axilla, chest, lower back, buttocks, and other skin folds. Many places they have reported 90% of patients, but in India, about 5 to 7% of cases only of scrub typhus are do you see this SCHAR. It's easily missed in pigmented and darker skin persons, and so that if SCHAR is seen, then it is clear that it must be scrub typhus. But the absence of SCHAR doesn't mean that there's no scrub typhus. Scrub typhus, as I said, not only is a febrile illness, but it can cause myocarditis, it can cause hemorrhages, it can cause delirium, it can cause meningitis, it can cause pneumonia, pneumonitis, and for long what we used to think is Japanese encephalitis in Gorakhpur, a study led by Dr. Narendra from NCDC and along with ICMR found that majority of persons who had acute encephalitis syndrome, which we would call as Japanese encephalitis, had high titers of IgM against scrub typhus. So they confirmed that what was known as acute encephalitis and Japanese encephalitis in Gorakhpur was actually scrub typhus occurring. Scrub typhus, as I said, is normally between the rodents and transmitted by the mite, and human beings are only accidental hosts, and they do not transmit between themselves. So the clinical features of acute undifferentiated febrile illness could be challenging because they are sudden onset of high fever, cough, rash, headache or body ache, SCHAR in some cases, swollen lymph nodes, nausea and vomiting, and severe symptoms include confusion, seizures and coma. Once there is suspicion of scrub typhus, you would find that the platelets are decreased, ALT is more than 100, and procalcitonin is also raised. The diagnosis is of paramount importance because delay in diagnosis leads to more mortality. If a person is identified and treated quickly, the mortality is 1.4%. While if the diagnosis and subsequent treatment is delayed, then the mortality could be as high as 30%. The biomarkers which could be examined, the easy one was the antibodies, and normally by the time the clinician think of scrub typhus and the time has passed, it is antibodies which are tested. But whenever you want to make a diagnosis on the basis of serology, ideally you should have two samples collected 2 weeks apart. Then you will see tighter movement and you can make a diagnosis. That has been one of the biggest problem in India in making serological diagnosis. On the other hand, detection of the bacteria which is present in the first few days is very important, but we did not have the means of doing it because culture has to be done in a biosafety 3 lab since it is highly pathogenic, or we could do PCR, which now is becoming more and more common, but still access to the diagnostic test is limited. So the 4 pillars of laboratory diagnosis are so first is the laboratory diagnosis is essential because quick laboratory diagnosis with treatment would save many lives. What we have 4 pillars for laboratory diagnosis. One, as you know, would be pathogen detection, pathogen isolation. Second will be molecular assays, which would also be a direct demonstration. Third is antibody detection, that is indirect assay. And then recently the antigen detection by IHC or immunoperoxidase has become possible in tissues. So ideally, molecular would have been the best. And before COVID, very few labs were capable of doing PCR. Now that we have more than 3,000 labs spread all over India, that should not be the excuse anymore that we cannot do molecular method. But you must know how many days have passed since the onset of fever, because the bacteria is present in the first 10 days. So if 10 days have passed, then molecular methods will not be the ones to do. If 10 days have passed, then it's best to do a serological test. So the early window is if the person has come within 10 days, you must also always do a PCR test, and if it is after 10 days, then a serological test will do. In the past, the trouble let me first just deal with the pathogen isolation, which is not recommended. It is only recommended for this is not recommended for diagnostic purposes of a normal lab. This should be done only in a BSL-3 containment lab, but it is essential for some of the reference labs which have BSL-3 facilities to do the culture, though it will take time, but you will be able to study the pathogen and the variability that it has much better if you have cultures with you. So it is recommended for reference lab. What was recommended for adequately equipped lab was indirect immunofluorescence assay, but this was the gold standard, which was flawed, partly because it is operationally impractical, requires paired sera, acute and convalescent, sample taken weeks apart to demonstrate a fold-fold antibody titer rise, useless for day of transmission treatment decisions, antibodies will appear after 10 days. So if a person has acute fever, then this will, IFA would not be able to uh, detect scrub typhus, and it is highly compounded, and there was high uh, person to person person variability in reading the result. So though indirect immunofluorescence was identified as the gold standard, but it's a flawed gold standard. As a consequence, diagnosis of scrub typhus suffered. It was noticed that heterophil antibodies uh, are available, which could be like agglutination, and is like Vidal test, which is known. This is known as Will-Felix test after the two scientists who described this. Will-Felix test is looking for heterophil antibodies against Proteus vulgaris or Proteus mirabilis. In scrub typhus, you would find high titer against Proteus mirabilis OXK. Uh, Again, this is easy to perform, and normally the inadequately equipped labs in India are quite happy performing this test. But and NCDC says that their experience has been that in resource poor setting, the sensitivity and specificity is is uh, is adequate, which is not really true. And high titer in single specimen has higher positive predictive value. Again, it's a doubtful variation, because unless you have a positive control, you cannot make this kind of comment. But at the same time, they have stuck to what they've been saying, and even in the frontiers in public health in 2024, they said that they're going to do a surveillance study where development and implementation of a strategy for early diagnosis and management of scrub typhus, an emerging public health threat. But as I've been trying to say, this becomes an oxymoron, because antibodies do not appear in the first 10 days, and you would save lives if you diagnose in the first 10 days and give treatment. So, but they want to do Will-Felix test, that means not learning from experience from others. What is also there is that the clinical features are non-specific. So since this is non-specific, you must also rule out dengue, you must also consider typhoid, you must also consider leptospira, and that makes it tough. So it was persons working on scrub typhus that they came across a 56 kDa type specific antigen, which is present in all isolates of TsutsugamishiIgMIgGCard, and they could identify but this is a variable type specific antigen, and it can if you sequence it, you can recognize 30 different serotypes or genotypes of the virus, and that complicates the vaccine development as well as diagnosis sometimes. So the immunodominant antigenic target for antibody detection is 56 kDa protein, which comprises 15% of pathogen's total protein. All infected individuals develop antibodies against it, but as I said, it takes 10 days for the antibodies to develop, so that detection of antibodies should be useful for surveillance, but for diagnostics, it leaves much to be desired. But what it did was that the advantage was that since the recombinant antigen 56 could be made available, then companies could make ELISA or lateral flow, so that instead of relying upon uh, indirect immunofluorescence, which required the presence, the availability of a fluorescent microscope, of also microscopists who would be able to differentiate and suffered from that. IFA suffered from person to person variability. You could get ELISA or you could get lateral flow, which could then democratize the diagnosis from a reference lab to an ordinary lab. And there they notice that ELISA IgM gives you good results, and so does IgM in lateral flow. For ScrubTyphus, this could be useful as antibody detection, but for spotted fever, rickettsia, as well as murine typhus, it was suboptimal. So the biomarkers again, if you are looking for bacterial load for it was in the first 5 days or first 7 days, then you have IgM, which will show acute immunity and which would show presence of recent infection, but IgG detection will show long lasting, and so IgG is not recommended for diagnostic purposes. For serology, for surveillance, IgG is fine, but for acute diagnosis of acute infection, what you need is IgM. Again, the trouble is that it takes at least 10 days for the antibodies to appear. So it is not. It is useful for the diagnosis of ScrubTyphus, but not for early diagnosis of ScrubTyphus. So for indirect diagnosis of humoral immunity, you should look at if it is less than 1 week, antibodies might turn out to be negative, but if it is more than 1 week, then you will find that IgM will indicate that the presence of recent infection, while IgG would indicate that the infection has been much longer. So comparing the arsenal of serological tests available, we had Will-Felix, IFA, the historical gold standard ELISA and rapid test, and you'll find that the sensitivity and specificity of ELISA is as good as that of IFA, and though the lateral flow could be slightly less sensitive, it is of low cost and is easily available. So as a consequence of development of ELISA, IFA has come into disuse, and normally IgM ELISA would be then using recombinant antigens would give you the right results. But again, the problem was that it will take at least 10 days before. So lateral flow and recently described surface enhanced Raman scatter has been made available commercially, and these tests may be useful for doing the test as point of care testing. So the third pillar, which in India becomes the second pillar after the culture, which is not to be done, serological tests, you have IFA, which is flawed gold standard, will detect IgM and IgG at 78%. Limitations is expensive, requires a fluorescent microscope, and suffers from severe subjective inter-observer variation. You have ELISA, which is the scalable solution, objective, automated, ideal for high volume surveillance with 70 to 100% sensitivity. It overcomes subjectivity, but it may have region specific cutoff values, and so I would strongly ICMR in Odisha, instead of doing Will-Felix, they must do ELISA if that is what they want to do, to find out what is the burden of infection by ScrubTyphus. Lateral flow is point of care, which has rapid 30 minutes turnaround time. There could be it could be slightly less than ELISA. And of course, Wilfelix is cheap, semi-quantitative agglutination. It has low sensitivity and low specificity, and should have been something of historical importance rather than something that we want to do in our reference lab. So we have moved from the original uh, scrub typhus infection diagnosis, and now we move to IgM, IFA, IgM. We moved on to IgM ELISA, and but still, as I've been saying, that means that it takes 10 days at least must be there. Otherwise, you will get a false negative result. So, if the fever, that would mean that scrub typhus ELISA would not be read without knowing how long the fever has been there. Because if the fever is of less than 10 days duration, you would get a false negative result. So, to cover up that problem, you have to offer uh, for early phase detection, you have to have molecular diagnostic test, and nucleic acid amplification is the answer. Real-time PCR has high value, and of course, in the recent past, thermocycler free isothermal lamp has also become available. It is targeting multiple targets. 56 kDa is a favorite target. HTRA and GROW-EL are another, and 16S ribosomal RNA would again be a specific target. Normally, a multiplex is done. More than one gene will be targeted, and at least two of them must be present so that you can be definite that you're dealing with scrub typhus. And this is possible in the first 10 days. If more than 10 days have already passed, then as we've been discussing, serology is fine. It's best to get 2 samples if you can. If not, you can look for IgM, and high titers of IgM would indicate that it is a recent infection. So the molecular arsenal which is available is real-time PCR, nested PCR, and LAMP or RPA is recombinant polymerase reaction. In real-time PCR, there's good analytical sensitivity, is offered reduced contamination, quantitation is possible, and multiplex is possible. It is limited by relatively high cost, but the more you do, the cheaper it becomes, as we noticed in SARS-CoV-2. Thermocycler is normally available now in at least 3,000 labs, and training, no specific training is required for scrub typhus PCR alone, but if a person is trained and already approved by ICMR and NABL, then there is no reason why the lab should not do PCR for scrub typhus. LAMP is something which is emerging, and that's what it will require is a cheaper system, and it could be even naked eye reading of results. So the genes that have been targeted are 46 kDa TSA gene, the primary immunogen gene, highly diverse, useful for strain characterization, but prone to false negative in varied endemic regions, so that only one gene will not be required. The other gene this 56 kDa gene should be detected. 47 kDa HTRA gene is outer membrane protein gene. It's highly specific marker, increases. It is utilized in multiplex PCR. Then you have GROW-EL gene, which is heat shock protein. Again, this will be commonly present. Then more specific will be 16S ribosomal RNA, because ribosomal RNA is a good target for detection, for specific detection of any pathogen. Ideally, 3 genes at least should be tested, and 2 of them should be positive for making a diagnosis. So you have conventional PCR, or you can have nested PCR. Real-time PCR is what is normally preferred, and loop-mediated is emerging. It's also there's a thought process that instead of blood, where the detection of of bacteria may be less, if you can, if Ishchar is present and you can get sample from Ishchar, then that will be preferred for PCR, because Ishchar will be caused by the growth of the bacteria at that site. So for confirmed diagnosis of scrub typhus infection criteria, you have either positive culture, which as I said is not recommended because it should be restricted only to the reference labs. You have acute IgM, you have rising IgM titers, and positive multiplex PCR. There are new methods available as immunosensors, DNA sensors, and aptamer sensors, and these have various methods of detection, and they will be potentially more sensitive and suitable for field deployment. The scrub typhus lamp have been propagated, but I feel that CRISPR Cas2a, and especially if it is single tube, one pot using detector system, where the color will change if it is positive, maybe the test which would be most suitable for India, since we have specific gene identified. Many scientists are working on CRISPR, and it is possible to have isothermal detection of even one pathogen. And so CRISPR one pot detector may be something that you should look forward to that in the future. So what the lagging front, of course, is murine typhus and spotted fever. Their progress still has not occurred. The diagnostic to treat will be input patient has undifferentiated febrile illness in the tropic, especially in the fever. If the you must inquire about the how many days the fever has been there. If it is less than 10, you should prioritize for PCR. If it is more than 10, then go for ELISA. If rash is present, then take that. Otherwise, take blood and look for and ultimately make a confident day of admission application of targeted anti-rickettsial therapy, which could either be a doxycycline or a macrolide. This is indicating overall the sensitivity and specificity of serological and molecular methods, and you'll find that, and in the future we could hope that we'll have IgM capture ELISA. We would have chemiluminescence, which will be much more sensitive and will be able, and of course now we have cell-based IFA, or they have removed the fluorescent tag with HRP, so that it could be as a peroxidase method. In the future, we could have next generation point of care where fluorescent nanoparticles will be more sensitive, and of course we could have multi-gene PCR where you're looking at a single copy, and of course next generation sequencing is what is going metagenomic next generation sequencing in reference lab, just as it happened in SARS-CoV-2, would help in identifying whether different serotypes or genotypes are circulating in different regions, and to keep track of how they're moving about. So when there's clinical suspicion, in early stage go for PCR, in late stage go for antibodies, and of course if there's unresolved, then send it to a central lab where metagenomic NGS will be done. So we have serological methods which are indirect, and we have molecular methods which are direct, and which are more sensitive and specific, while antibody tests are less sensitive and would be delayed. So a negative antibody should not make you confirm, especially if it is less than 10 days, that it is not scrub typhus. Wherever possible, we should do nucleic acid testing, but we could go in for better for ELISA or point of care testing. And if we have ISCHAR, that is the one which would help us identify. So clinical suspicion, increasing use of laboratory and using the right test would help in identifying the patient as early as possible. So the immediate goal will be to replace subjective IFA with objective ELISA and a rapid diagnostic test combined with early window PCR. The future horizon will be we can't rely on retrospective blood banks. The path forward demands prospective clinical studies in endemic areas to validate next generation highly sensitive point of care diagnostics, and the ultimate payoff will be building this precise, unbiased evidence base in the foundation prerequisites for the future development of effective rickettsial vaccine. Putting it all together would be that in the first few days of illness, since the clinical features are going to be non-specific, the clinician should have a high infection, which could also mimic Japanese encephalitis or acute meningitis syndrome. And so we should be aware that scrub typhus is a disease which might during the monsoon and which may be present in the location. We should then, depending upon how many days have passed, order either the molecular test or the serological test. And even if the diagnosis is not confirmed, the sooner a person is given the treatment, the better it will be. If a clinician feels that there is scrub typhus, diligently for the issue.
Professor Rattan, we lost your audio, sir.
And bite. So clinical suspicion is required, the right test is required, and the treatment, which is cheap, should be given if the clinical suspicion is there. I thank you for your attention, and I hope that this is what we can put all together and make sure that nobody dies from scrub typhus.
Thank you, sir. That was a very well put together presentation. There were a couple of questions that the audience had, and I had one myself, but I'll ask the audience questions first. You know, we have one which says the ELISA kits available from certain companies are giving a cutoff of 0.5. This cutoff is uniform across the entire geography. Do you think that the labs testing in this kit might be giving erroneous result as the cutoff can be different as we are observing for other tests like dengue and lepto?
See, as I've been trying to say, when you're making a serological diagnosis of a case depends upon getting two samples. So, normally, when I looked at the kit insert, one they say is that there's a positive control. So the positive control must be over 1.5 OD, and the negative control must be less than 0.15. So first is to make sure in your kit is your positive control and negative control behaving the way it has been recommended. Then the kit will indicate that you try to find out how much is IgM. So you should go for a kit which detects IgM, not total antibodies, not IgG and IgM, because that will then confuse the issue. So if you want to make a diagnosis of recent infection, then follow the kit insert, make sure that the negative control is behaving the way it is, the positive control is behaving the way it is, and then there is a formula that most of the kits mention on finding out what is the level of IgM present. And yes, there is that paper by Dr. Amita Jain from KG Medical College along with ICMR where they have found 0.5 OD as the cutoff. You would find that if a person has, if you find persons who have antibody titers less than that or near about that, then you must get a second sample 2 or 3 weeks later, and you will find and do the test again. Both the first sample and the second sample must be repeated, and then you will be able to identify. So one is to only sit down and keep on saying, is this going to happen or that is going to happen, and the second is to find solution. But yes, as I said, most of them are using a recombinant 56 KDA protein, and it could vary from place to place. So you should not universally accept everything that is happening. But at the same time, you should try to find a solution rather than escaping that. And for diagnosis, wherever you have any doubt, go for 2 samples, but treat the patient at the same time.
Okay.
Because ultimately, doxycycline will save the patient's life.
In fact, our next question was around the same thing that doctors charging doxycycline prior to testing for scrub typhus sometimes. Empirical treatment causing false negative results. How do we counter this as a diagnostician?
No, see, ultimately, the right thing will be that you take the sample, and then one is clinical judgment. So and we all agree that in the first 3 days there would be the clinical features of dengue, of typhoid, of malaria, of scrub typhus are same. So that means that you don't treat every patient as standalone in the universe. You are seeing what is available. For many years, you know that Gorakhpur, we would keep on talking about Japanese encephalitis. Vaccinations were given to the population. Anti mosquito activity was taken, and it had no effect. So it was only when the right test was done, and they found that it was scrub typhus.
Oh,
So it's not that all cases. So ultimately, clinicians must use their acumen, and we must have dialogue with the clinicians so that lab diagnosis is not made on a single test with a single antigen and then saying either 100% this or 100% that. You have to look at the totality and make your diagnosis. But yes, after the sample is taken, if the clinician suspect that this scrub typhus, I would suggest he should. If he suspects, see, don't give to all comers. All comers, scrub typhus is not something that he suspects.
true.
So first is malaria. First you would suspect malaria, then you will suspect dengue, then you will suspect typhoid, and finally, if nothing works, then you say it's scrub typhus. So at least look at the ischar, look at whether it's there or not. If you're going to spend 1 minute per patient per OPD consultation, then naturally the lab is not going to be of much use.
In fact, good that you mentioned ISCHA, sir. But how common is ISCHA in patients? Because currently
Oh,
symptoms
5
are
to
not.
10, 5 to 10%. Yes, it's very, very rare.
Yeah.
But Maybe, see, one is in the whites it is easier because you know that there is the redness is clear. But that means you have to spend more time. And if it is negative, it doesn't mean that there's not scrub typhus.
Hmm. So how do we, you mentioned it's 5 to 10%, which means a lot of cases will not have it. And so how
Yeah.
do we overcome this non-prescription issue due to lack of typical scrub symptoms?
See, there are two approaches to it. If the person has come within 10 days, then a multiplex PCR, which detects all the undifferentiated causes of fever, that means malaria, dengue, typhoid, leptospira, and scrub typhus, would be the answer. And many labs have introduced it, but somehow or the other, the cost has always been a factor, and maybe the rapidity of the result, because unless it is available in every district hospital, is going to be, is not a starter. But yes, multiplex PCR would then answer that in the first week itself, and by the end of the day, once the test is done. If that is not there, then it is more by exclusion. So there are two ways of diagnosis. One is by that you have a suspicion, and then you test whether it's malaria or not. If it comes negative, then the second one is you suspect that it's dengue. So you test for dengue. Then you find that's negative. The trouble is going to be that scrub typhus antibodies are negative in the first week. So it's a
And scrub is also at
self-fulfilling.
the bottom of the testing pyramid. If you look at the testing algorithm in the testing pyramid, it's right at the
See,
bottom.
and in the testing, we should always test in the principle that if the result is going to make a difference in your treatment, you must prioritize. So we cannot be testing uselessly. If you test for antibodies in the first 10 days for scrub typhus, then you're wasting your energy. So that means the fever must be there for more than 10 days before you test for IgM. But for the right test will be PCR.
Of course, PCR will catch the first strand at the first day. So there's no.
So it is, while suspicion will be on the basis of both diagnostic test as well as ruling out. If it is not malaria, if it is not typhoid, if it is not leptospira, then you feel the fever during this time would be would be scrub typhus.
So one last question, because when eventually everything comes down to either a time issue or a cost issue. So when we went look at your framework, which implies running more than one test per febrile patient during the peak season. So I'm just thinking out loud, in a district hospital which is handling uh, AUFIs or undifferentiated fevers at volumes, uh, there's a cost involved. Is there a triage rule, a day of fever cutoff, a CRP threshold, an SR finding that tells a clinician when the second test is justified and when it isn't? Because it would help put things in clarity perspective for our diagnosticians.
Well, if you come to think of it, then as you know, there are instruments available which will do CBC and CRP, and machine learning has indicated that the response to bacterial infection and viral infection can be differentiated if you if you analyze CBC and CRP. So that's, as I told you, we made an app. An app is available in Switzerland, and
Okay.
we'd copied that app, and the instrument is available from one of the company, Japanese company in India,
Hmm.
where with 3 drops of blood you can get CBC and CRP, and by using the app in minutes you can know whether the chances of bacterial infection are more or chances of viral infection are more. So this could then tell, because one is you want to know whether uh, whether it's a treatable disease or you have to give only symptomatic treatment. If it is dengue, then in dengue you want to know whether it's dengue or not, because and then you want to know whether a person has dengue, severe dengue, because on the third or fourth day they could be bleeding, or they could be they could be shock. So you are forewarned that this is what is going to happen. So you should be ready for that. Though there is no specific treatment up till now, and of course vaccine has now been allowed, so maybe by next year many persons will be vaccinated, but we have to watch that in a different way altogether, because unless it gives 100% protection, second infection is the one which can lead to the problems. But that is one. Malaria can be identified within minutes, so malaria can be done, dengue can be done, typhoid takes
So why
time.
not put this in the fever panel then? Scrub typhus along
Yes,
with the
but as I said, all these are unless it's an antigen detection, antibodies will come on the
later
tenth
in the
day.
day. Later in
So unless so, the solution is to do multiplex PCR for uh, for uh, for tropical fever. So tropical fever, undifferentiated tropical fever, would include typhoid, will include malaria, will include enteric fever, leptospira, and scrub typhus. So
What is
that's
your
where
thought
you
on
would catch.
CLIA, sir? Does CLIA fit into this algorithm somewhere? Chemiluminescence?
Chemiluminescence is going to detect antibodies, so that will have to wait for 10 days.
Hmm.
Or maybe less because it's more
More
sensitive, so
sensitive.
it might detect it by 7 or 8 days. But the biology is that the antibodies will take some time to appear. By that time, you would have already diagnosed malaria, you would have already diagnosed dengue, because dengue NS1 is an antigen
Yeah.
which is present one day before the fever comes. So we need to look at what is the analyte we are detecting, when the analyte is present, and when it should be done. But yes, it is clear that in scrub typhus, the sooner you suspect and you take the right test, you would be able to save the patient, because it's a treatable disease.
On that note, thank you very much, sir, for answering our questions and, of course, for the extremely detailed discourse around this. We must do another session sometime around dengue, and there are a lot of myths around dengue, right? Which we hope, with your experience, one day we can counter. So
Yes.
maybe in the
Uh,
coming month we can work out something around that as well.
Sure. It'll be my pleasure.
Thank you, sir. A pleasure to host you.
Thank you.
Ladies and gentlemen, thank you very much for joining us today. This was an eye-opening session around scrub typhus or susugamashi, and we look forward to interacting with you on our next webinar around the subject of dengue, given that we are in the monsoon season. Till then, good night and Shubhratri. Jai Hind.